Good evening. We are coming to the fag end of a good conference, and this is the time when Jemima Rodriguez is celebrated, and I think in Kerala we have to celebrate our gynecologists because the statistics say that the maternal mortality, infant mortality, everything is in the Western standards. So we are with superheroines to begin with. Now, the credit should go to them. And they are the people who give compassionate care to the maximum. We always teach about compassion. They are dealing with real compassionate care. Coming to this topic, Kerala, yesterday we celebrated Kerala Piravi. And we celebrated many things in Kerala. The weather, the nature, the education, healthcare. And Kerala is also the capital of diabetes and infectious diseases. We have at least a dozen of infections in Kerala all the time. And the number is increasing. Now today's paper says we have scrub typhus as well, coming from abroad. So there is a wide range of infections in this part of the country, and it's very difficult for someone to talk about all of them in this given time. So Professor Radha is going to concise, I hope, her talk to very important infections which have poorer prognosis in pregnancy. Over to Professor Radha.
Thank you, sir. Respected chairpersons, my dear teachers, colleagues, friends, and students in the audience. At the onset, let me thank the organizers of this Monsoon CME for calling me over here to give a talk. My thanks are due to my professor, Dr. Sharma, without whose guidance I will not be standing here. And I would like to thank Dr. Krishna Kumar for his advice in leading me through this maze of infections. I've been asked to reduce a book to a capsule. So let us see what I can do. Now, this is a scenario of a 25-year-old primee in the second trimester who presents with a fever of 5 days with loin pains and smoky urine. And on examination, the patient is febrile, tachycardia is there, respiratory rate is 25, blood pressure is 90/50, and on standing it drops to 75 and SpO2 is 94. Now, what is the clinical diagnosis? Yes, it is obviously a urinary tract infection, and because of the loin pains, it is an acute pyelonephritis. Now the question is what investigations you would do and how would you assess her illness and what would be the early warning signs. Sir specifically told me to give you advice regarding when to refer the patient and when not to refer the patient. So what investigations do we do routinely? Of course, a urine routine and a urine culture, which a midstream urine is enough. And obviously, because of all those vital signs, we would do a complete blood count, the renal function test, a blood culture, ultrasonogram, and all the rest of the works that you do. Now, how to assess her illness? And what are the early warning signs which would warrant an early referral? Now, there are several scoring systems in emergency medicine for patients other than pregnancy. Now, one of them which will be useful to obstetrics is this obstetric early warnings score, which has various parameters like this. On either side of normal, you have 3 on each side. And if you take this patient, her score comes to around 8. And if you have a score of 9 or more, that portends that this patient is likely to go in for complications, likely to go in for renal failure, ICU care. So this is one of the scoring systems that we can use, which is modified for obstetrics. And there are several other specific scores. Each institution may use its own score. Sepsis in obstetrics is what I showed, and there is an obstetric early warning score and a maternal obstetric early warning score. And the sepsis in 2025 pregnancy, now it specifically mentions some things which we must remember about pregnancy. the early recognition of infection and early recognition of signs of rapid deterioration are mandatory. A prompt administration of a broad spectrum antibiotic which would cover gram-positive, negative and anaerobes within 1 hour. And the care should be multidisciplinary, and it should include early warning signs. Consider sepsis in any patient who presents with multi-organ dysfunction, and the sepsis care bundle is what I discussed just now, which should include serum lactate, first antibiotics within an hour, and as soon as you start antibiotics or just prior to that, send for cultures, fluids, and early use of vasopressors. So this is the modification that has come up in sepsis 2025 in pregnancy. So what we saw was an acute pyelonephritis, the symptoms of fever, loin pain, and the patient is toxic. Usually this happens in second and third trimesters. Complications like septicemia, ARDS, MODS, anemia, renal failure, all these are common, and obstetric complications are also common. And mandatory that you do a urine routine and culture. And if you don't have any clue, the patient is extremely toxic and there is a severe infection, treatment is initiated with meropenem or ertapenem. But if the patient has only mild to moderate severity, you could start with cephalosporins. And this is another modification of our commonly used Q-SOFA. This is actually used for ICU setting. In non-pregnant people, the systolic blood pressure cutoff is 100 and in respiratory rate is 22. For modification in pregnancy, considering the hemodynamic changes in pregnancy, the blood pressure has been brought down to 90 and the respiratory is 25. There is a very poor maternal outcome, altered immune responses, physical causes, poor cardiorespiratory reserve, and various circulatory changes which you have already seen in the morning. And there is also altered pharmacokinetics of the drugs and a risk of vertical transmission of infections to the fetus. And as you can see, the poor fetal outcome may be because of the transplacental transmission or peripartum transmission. And lactation actually is lesser on the list. So, which are the infections which could give a very serious maternal outcome? As we saw, UTI, pyelonephritis, sepsis or ARDS due to any organism, hepatitis E, which I'm sure you heard about in the morning, H1N1, COVID, malaria, dengue, CMV, lot of infections are there which have a very bad portent for the mother. When you come to the fetus, the classical infections which can cause a very poor fetal outcome are the torch infections, syphilis, HIV, listeria, parvovirus, Zika, malaria, streptococcus, to say a few. Now we come to the next scenario where a 30-year-old lady with a 22 weeks pregnancy. Now the history can be like recurrent abortions, it could be a late trimester fetal loss, it could be some fetal malformation which has been noted either earlier or in the present pregnancy. And apart from routine and your FOGC antenatal routine infection investigations include only, what are the investigations that you do? HPSAG, HIV, VDRL, and check for vaginal infections. So none of the torch screening is mandatory in the first trimester, in the initial antenatal visit. So when you have a patient who comes with such a bad obstetric history, there you have to order the other tests like torch. Because I got a question asking when to do torch. Please do not ask for a toxoplasma titer in a first trimester in any patient who comes for first antenatal checkup. Also, when the patient is residing in a malarial endemic area, whether the patient has multiple partners and cat exposure. Now, it is very important that the pregnant lady should not remove the litter of the cat. If the cat is domesticated and does not go outside anywhere, the risk of getting toxoplasma from that is very low. So do not bring any new cat into the house while the lady is pregnant, and a Parturian cat may be dangerous. So coming to toxoplasmosis, the clinical manifestations, it may be just like any other viral fever if you're getting an acute toxoplasmosis. So it produces a fever, myalgia, generalized lymph node enlargement, etc., etc. It depends on the species of infection. Now, when you have a prolonged toxoplasma, the eye gets affected. So chorioretinitis is a long-term sequelae of toxoplasmos, and it also depends on the immune status. Immunologically incompetent patients may develop a CNS toxoplasmosis. The fetal effects again depend on the stage of pregnancy, the stage of maternal infection, the type of the parasite, and the maternal immunity. Acute infection in the first trimester carries maximum risk for the fetus. And if you are just IgG positive, it does not mean anything if your eye is normal and you don't have any symptoms. Because a past infection with a toxoplasma, the titer can persist for years. Unless you have symptoms or you have eye involvement, there is no need to treat them. Even if there is a lymphadenopathy, there is no need to treat. But a recent occurrence of IgM positivity or seroconversion, IgM goes and IgG comes, that means there has been a recent infection and they may require treatment. And the fetal consequences which we can pick up are intracranial calcifications, chorioretinitis, microcephaly with the hydrocephalus. So if these are there, then definitely there is a need for treatment. Now malaria, we don't see so much of malaria now here, but with this advent of these people from Northeast, we have started seeing complicated malaria in our parts. So it has maternal effects and the fetal effects, and all this severe malaria with falciparum are more common in a pregnant lady. So we may have a Northeast lady with no history of any diseases coming with a severe malaria. And it has adverse fetal outcome also. And treatment in the first trimester is quinine or clindamycin. Second and third is our conventional artesunate. If there is a chloroquine resistance, mefloquine, quinine, clindamycin, artesunate can be used. Now this is one thing which has come up. WHO has recommended intermittent preventive treatment in pregnancy with sulfadoxine pyrimethamine, especially in the first or second pregnancies. And this consists of 3 tablets of sulfadoxine pyrimethamine, monthly doses given throughout pregnancy. Now we have a third scenario where the lady comes with the first trimester with fever, myalgia, eye pain, rash, and various combinations of pharyngitis, diarrhea. And there is a history of travel, consuming undercooked meat, poultry, unpasteurized milk products. And you find that there is a lymph node enlargement and a hepatosplenomegaly. Now the differentials are quite a few. IMN, dengue, parvovirus, CMV, toxoplasmosis, HIV, syphilis, listeriosis. Now of the lot, a parvovirus infection may be totally asymptomatic in the mother. We have had personal experiences where a lot of children with infection came and the mother did not even have a fever but developed a fetal demise. So coming to dengue, it's one of the most serious and severe infections. Simple dengue fever just comes and goes. Just because you find a low platelet, it does not mean anything. The fever and the low platelet just go. But in the second phase of the illness, where the antibody response occurs or where there is a capillary leak, that is the most dangerous phase in pregnancy. And this phase is very severe. It may be fatal to the pregnant ladies. And the problem is that during this phase, you find that there is early warning signs, which you all might be familiar with. WHO has clarified the number of times the lady vomits, number of times there is abdominal pain, platelet drops, BP drops. So many symptoms are given. And one finding in ultrasound that may portend a bad prognosis is pericholecystic fluid collection. In a pregnant lady, it is very, very difficult to pick up serositis or serosal effusions. And this will mimic HELP, pneumonia, pulmonary embolism, and other obstetric accidents or infections. And there is a very high risk of fetal compromise. Now, some of the red flags in pregnancy in dengue are when you have a fever, but when you don't have a fever, but there is a resting tachycardia, a narrow pulse pressure, of less than 20 millimeters or a drop in the pulse pressure from 30 to 25 often heralds an impending dengue shock. Postural BP fall or change in the BP when in a patient whom you may mistake it for a supine hypotension. If there is dengue positivity, please be careful. A respiratory rate of more than 25 is a warning sign. Patients may not even notice that they are dyspneic. And one clue is that you have to correct the metabolic acidosis early, otherwise you will go for a shock and a MOS. And since there is not much of thirst in a pregnant lady and urine output may not be a good indicator of an impending renal failure, don't go by urine output. And to sum up these practice pearls, which we have discussed in the morning, the most important thing is you should have a low threshold for blood transfusions. The Paxil should be given in any patient, any pregnancy where there is a loss of more than 500 ml of blood. And also, when you are treating the lady with IV fluids, you have given enough IV fluids, the clinical signs do not improve and the patient's hematocrit keeps on dropping. That suggests that there is some bleed somewhere and you may have to give blood transfusion. Platelets are indicated only if there is a bleed and if the platelet count is less than 20,000 or even 10,000. Otherwise, no bleeds, no transfusion. If you are planning a delivery, a count of normal delivery 50,000. If you are planning an intervention, 75,000. This is what Dr. Neeraj was discussing in the morning. And avoid induction of labor, because this phase lasts just 48 to 72 hours. Support the patient with fluids, blood products, platelets if necessary. I repeat, if necessary only. Then, even if there is a thrombocytopenia or other signs, wait, because the induction of labor may be hazardous for the baby as well as for the mother. Now, HIV is something which is beyond us. I would like to concentrate more on the syphilis. This is a situation which is coming back. Our dermatology department sees syphilis in various stages almost every day. So, you have to screen the patients for syphilis by doing a non-treponemal test like VDRL. Now, if that is positive, you repeat a treponemal test. If there is no past history of syphilis, then on the spot, a single dose of benzathine penicillin has to be given. And further workup has to be done in a higher center. So that is something which you will refer to a higher center. So this is a guideline given. Now, varicella is a very common problem. Maternal varicella usually doesn't cause fetal problems. Congenital varicella, the risk of transfer is only 0.2 to 4%. More often it occurs by contact during delivery or by breastfeeding. The maternal complication that can happen is maternal pneumonia. The fetus intrauterine transmission can cause a few scars, IUGR, neurological or ocular problems. The treatment for the mother is acyclovir, routine dose, routine time. There is no teratogenicity for acyclovir and it is absolutely indicated if the mother has varicella. Now, prophylaxis, the ideal prophylaxis is to give a specific varicella zoster immunoglobulin if the mother has had a contact with varicella within the first 10 days. There is no role for giving acyclovir as a prophylaxis. Vaccinations should not be given in pregnancy. Live vaccine should never be given in pregnancy. But once the delivery has happened, in the postpartum period, the mother may receive 2 doses. Or if there is a contact and the mother does not receive all these things, immediately after delivery, give her 2 doses. Also, the household contacts should be given 2 doses of the vaccine. This, I think you've seen in the morning, hepatitis E is a fulminant failure, very high risk for failure. And antibiotics, we have already discussed all this, penicillin, cephalosporins, carbapenem, fosfomycin. They are very safe. Nitrofurantoin in the 2nd and 3rd trimester, trimethoprim only in the mid-trimester. Now, vaccines, please concentrate on the pregnancy. The only vaccine that can be given during routine pregnancy is a Tdap. Influenza inactivated vaccine may be given if there is an epidemic and the lady is at a high risk for developing influenza. This is the guideline from your FOGSI. If you follow FOGSI, it is the best guidelines that I've seen. The American College recommends respiratory syncytial virus vaccines in the last trimester. Most important is prevention of infections by hygiene, hand washing, food safety, avoid unsafe travels and pet handling. Because infections can occur, but the outcome of infections in pregnancy is unpredictable. So prevention is better than cure. And this is our aim, a happy, healthy mother and a happy, healthy child. Thank you so much.
When a master speaks, they don't cover the topic. They just uncover the topic. And all the important points what she mentioned are pearls. Fantastic talk. Please give her a big hand. Thank you, madam. Let's continue the question and answer session and discussion. Any questions from the floor?
Thank you, ma'am, for that wonderful overview about this vast topic covering almost all the aspects. Basically, in managing in pregnancy, you have to remember the normal physiological changes, the decreased immunity and the decreased lung capacity of the pregnant women. And so any infection in pregnancy can rapidly deteriorate. So an aggressive antibiotic therapy is what is needed. And regarding the chickenpox exposure, the recent guideline says you can offer acyclovir tablet as a post-exposure prophylaxis.
No, madam. See, chickenpox virus goes into the intracellular thing. Acyclovir will not act on it. It is a wrong guideline.
Okay. Thank you.
The only prophylaxis that you can give is varicella zoster immunoglobulin. The dosage is 125 per 10 kg. Maximum dose is 625. Now, we can get it on demand. It is not routinely available over the counter. If you don't have it, you may opt for an IVIGG, simple immunoglobulin, that is 400 milligram per kg. But no, acyclovir has no role as prophylaxis.
Okay, thank you.
If the IgM is positive in pregnancy, what is the treatment that you recommend and how long you have to give it?
Madam, it depends on the stage of pregnancy.
Yeah.
If it is less than 14 weeks, pyramycin. If it is not, you have to give sulfadiazine pyrimethamine. That has to continue throughout the pregnancy. If it is IgM positive, and also look for other signs and follow the titer, follow the fetus, because if we do not know whether the fetus is infected or not. So repeated ultrasounds to watch for fetal problems. It is important.
Yeah, do we need to continue the treatment till end of pregnancy at intervals?
Yes.
So that is one thing.
Yes.
And what is the role of azithromycin in this treatment of toxoplasmosis?
It's not the first line drug. Azithromycin is one drug which can be given in pregnancy, but it's not the first line. Syphilis, they have mentioned azithromycin, but it is not very good to treat if you have a benzathine penicillin.
Not in syphilis, toxoplasmosis.
There are several guidelines. I checked several, but I think your FOGSI gives you a very good guideline about all these things.
This pyramycin about 2 weeks interval and like that.
Pyramycin you give till 14 weeks. Once the lady crosses over 14 weeks, you have to convert to sulfadoxine pyrimethamine because that is a better drug.
Okay.
Ma'am, what advice can we give to a hepatitis B positive young lady who want to conceive?
Sir specifically told me to leave out hepatitis B, but the thing is, like, it is a chronic infection. First, you have to find out what is the status of infection in the lady. What is a viral DNA copy that is there? Treat the mother. And once the copies have gone down to less than, say, 1 lakh or 20,000, there should, if there is a normal liver, the cutoff is 1 lakh. Then you start pregnancy, because none of the drugs that are used for hepatitis B can be given in pregnancy. So she should be monitored by hepatitis B DNA titers and followed up.
Any more comments, questions? I think we can wind up the session.
Thank
you very much once
Thank
again,
you.
madam. This is an era of teamwork. This is an era of multidisciplinary care. So it's important that you take help of your colleagues whenever required. And that saves us and the patients. That's, I think, is probably to be kept in mind always. Thank you very much. Thank you, madam.
Thank you, sir.
Thank you, Dr. Radha. Professor Radha.
Thank you, Dr. Radha, for that clear and informative talk on infections in pregnancy.